Today, we are honored to announce Dr. Fredric Schiffer. He is a research associate at McLean and a part-time assistant clinical professor in psychiatry at the Harvard Medical School. Dr. Schiffer has been studying the relationship between cerebral laterality and psychological states since 1990. His hypothesis is that each hemisphere is capable of manifesting separate personalities, one side more troubled by past traumas than the other side. He also studies how near-infrared light applied to the forehead may act as a treatment for psychological problems, and including opioid use disorders. And he has a private practice in psychiatry in Newton, Massachusetts. And you may know, Dr. Schiffer is a prolific writer. You may have heard of his first book, Of Two Minds, The Revolutionary Science of Dual Brain Psychology. And his newest book comes out this October called Goodbye Anxiety, Depression, Addiction, and PTSD. You can find it on that website, dualbrainpsychology.com. And these are just a few examples of his work. He also has many other articles in reputable journals, as well as a number of abstracts. So clearly his contributions are influential to the field. He also has a webinar coming up at the end of the month, September 30th. And you can also find it on this website. And with that, I am going to stop sharing and hand it over to Dr. Schiffer.
Well, thank you. And it's a pleasure to be here. And I'm glad that you're interested in learning a little bit about dual brain psychology. So I know that your main interests are in photobiomodulation, which is an interest of mine. But in order to explain what I'm doing with photobiomodulation, I have to explain dual brain psychology, which is a novel theory of psychology. And it's the first psychological theory that I know of that comes out of rigorous science and that is supported by publications, mostly from Harvard, that rigorously test the hypothesis with high-tech things like evoked potentials and fMRI and anatomical MRIs. And we also have clinical studies that we conduct. And we're conducting one now for the National Institute for Drug Abuse. And they wanted us to try to treat mild and moderate opioid use. And what we found was that it doesn't exist, and that everybody that we're coming across is addicted to fentanyl. So it's become a fentanyl addiction study. And it's been a challenge to enroll people. But we seem to be getting very good results, that the majority of people are pretty dramatically reducing their fentanyl use. One patient who finished recently said he was going to dye his hair and come back as another candidate. But I don't have the results from that. Half are getting sham and half are getting active. It's an FDA study as well. And it would be the first device to get FDA approval if we wind up getting that. FDA has given us a breakthrough designation and has determined that our method and device have no significant risk. So what I want to do is talk about dual brain psychology so that I can explain what I'm doing with photobiomodulation. I'm not using neurofeedback. I've taken courses in it and bought the equipment and so forth, but I never really got into it. So I'm not criticizing it. I think that it helps a lot of people, but I'm not expert at it, and I'm not going to really talk about it. If somebody has some questions, we can discuss it. But so it's going to be primarily about photobiomodulation, but based on this psychological theory. So dual brain psychology has a few premises. One is that trauma is the cause of perhaps all psychiatric illnesses, and maybe not, but all that I'm familiar with and have seen. I define trauma differently. In other words, I think trauma is anything that harms us or hurts us or makes us feel insecure and interferes with our functioning. So it could be, but it doesn't have to be a rape or molestation or a beating or combat, which certainly are traumas. But I think that in human life, we can be traumatized by a critical parent or rejecting parent or a sibling who's bullying or peers who are ridiculing. So these are things that I think are traumas. Of course, we talk about complex trauma, but I think even that's a little more complicated than what I'm talking about. And then what happens is, say I have a rejecting mother. I have a lot of men whose mother said when the kid was 3 or 4 years old, you're a loser and you'll never amount to anything. And so when he gets to school, he's already feeling insecure, and so he can't pay attention. And then he's got attention deficit disorder, and the teacher's upset with him, and he doesn't get good grades. And then he's more insecure, and it keeps rolling until he gets in with a bad crowd and starts using alcohol. And then it becomes a question of, well, who's responsible for his alcoholism? Who opened the beer can? Well, he did. Okay. And so all of the trauma is forgotten. Hi, I'm Fred. I'm an alcoholic. And it ends there. It's my responsibility. And now I have a disease, and my disease is incurable. And I can go into remission, but I never get better. And that's a trauma. The one trauma leads to further traumas. And then if I can't work because of my alcoholism or my drug abuse or my rage, then that becomes another trauma. And the trauma keeps rolling on itself and becoming a problem. Now, one thing that I discovered that I'm going to talk about is that the trauma seems to get lodged more in one brain hemisphere. And what I'm going to talk about is that each brain hemisphere can support a different mind in normal people. And this comes out of the split brain studies. The troubled side can be either the left brain or the right brain. So there is a common feeling that all the bad stuff is in the right brain. But with a lot of people, particularly people with a lot of trauma, their left brain is holding more of the trauma. And with the affected brain is an affected mind. So the person has two minds, and that's the title of my first book, Of Two Minds. So if we stimulate one mind, one hemisphere, we get a personality change. It's subtle. The person has the same address and the same name, but they see me as critical like their mother was. And on the other side, I look empathic. And in some people, it's quite dramatic, as I'll talk about. So these are just a bunch of publications just to show that, this has been well tested. And this is only as many as I could fit on the page. So I was noticing in my practice, I was trained at McLean, and at that time, it was a bastion of psychoanalysis. And in the 80s, one by one, each unit became a biological unit. And then by the early 90s, we had an attending staff at McLean where I was one of the attending psychiatrists, and I had a private practice there and would get referrals from the different halls. And I see the patient 4 times a week, and Blue Cross would pay for 2 months. And by the 90s, Blue Cross was cutting down, and McLean decided they would save money by getting rid of the attending staff and hiring cheap labor, paying $40 an hour and charging $400 or something, and keeping the change. And I had already started doing research, so I stayed on at McLean as a researcher, but I was no longer a clinician. And they even tore down the building that we were in. We were in this beautiful building, and today it's a heap of debris. They didn't even make a parking lot out of it. I don't know why, but so today there's no talking with patients. So you go, if a patient goes in, he's in for a week, he gets medicated, and he gets told that he's bipolar, which is not a nice thing to be told. And he's discharged or sent to a halfway house, and the way psychiatry is practiced around the world today. So I think that psychiatry has lost its mind, and I'm trying to find our mind again. I'm sure that you've noticed that yourselves. And so I was steeped in Freudian psychology, but I wasn't seeing ids or egos or superegos easily in my practice, even though I knew what they were. But what I was seeing was that the patient would come in and he had kind of a very regressed personality. And as he got better, he became sort of a mature, normal person. And then something would happen and he'd become regressed. And then he was back to this regressed personality. And the regressed personality had a lot of the attributes of the id. It was had primitive thinking and immature behaviors. So instead of having the ego riding the id, it was really I was seeing like a shift in personality. And then I started reading the split brain studies again. I had read them in college and thought they were really fascinating, but I didn't really understand them. And that the thing that you have to understand about the split brain studies, and let me explain that. So here's the id and the ego. It found that clinically I was having problems with it. And so this is a paradigm shift. And so the split brain studies were done actually first in the 1940s and then in the 1960s. And Roger Sperry won the Nobel Prize for these studies. And essentially, they had patients who had intractable epilepsy and couldn't function because of their epilepsy. It was, happening multiple times a day. And so they decided to cut the corpus callosum. So the corpus callosum is in the center here. And so when they did that, a very interesting thing happened. There were really two personalities that became quite distinct. And so here's Roger Sperry, and Joe Bogan was the neurosurgeon, and Iran Zaidel was a graduate student who worked with Sperry. And so the idea here is that, so this should be cut here in this illustration. So this is the connection between the left brain and the right brain. And if you show something to the left visual field, it hits the medial retina. The retina is divided so that the lateral portion goes straight back, goes ipsilateral, and the medial portion crosses over to the opposite brain. So that this picture here shown to the left visual field is only seen by the right brain. And what that means is that if the right brain controls the left side of the body, and it controls the left arm and hand, and it can reach into the box and very easily pick out the chess piece from about 5 items that are in the box. If you put the box on the right side and the right arm and hand are controlled by the left brain, it has no idea what to pick out. That only the right brain saw the picture. And Sperry showed a photograph to a woman that he had been studying, and she started giggling. And so the left brain can speak. And she said, "You've got a funny machine, doctor," which was a confabulation. She had no idea why she was giggling. And Sperry showed a Playboy nude in the 1960s to her right brain. Her left brain, which could speak, her right brain is mute. You can give hand signals, but it's mute. So she's giggling, but the speaking left brain has no idea why she's giggling. So there really are two minds here. And they're both intelligent. They both speak English, and they understand what Sperry's asking them to do. And you can show political pictures, political figures, and they can give a thumbs up or thumbs down on both sides, or the left side can identify who it is and give an opinion. So the left side is like talking to an ordinary person, and the right side can give hand signals, and the hand signals often differ. So, and then there's a post-commiserotomy. Commiserotomy is the name of the surgery where you cut the corpus callosum that connects the two hemispheres. And after that, the two hands can fight over a sandwich. One hand wants to eat tuna fish, and the other hand wants a cheese sandwich. And these things are in the literature. One woman is buttoning a dress to put on, and the other hand is unbuttoning it. And another guy wants to smoke a cigarette, and his left hand connected to his right brain keeps putting it. And that goes away after a while as the left brain takes over and dominates. So one of the paradigms that's very used was to put two words on a screen. And so the word tooth goes only to the right brain because of the retina. And so the left hand can reach back and pick out the tooth, and the left brain can say the word brush. So I did a study with Bogan and Zaidel, which was the last split brain study in the California series. Sperry had died a couple of years earlier. And this was the first psychological inventory of the two hemispheres. And so what I did was I put a word on each side of the screen like Sperry had done, but mine were words about the question that I asked was, how much do you feel? One side saw happy and the other dishonest. And so there were positive and negative words. And both sides got all the words, but in different orders. And then they responded with each hand pointing to pegs. And we had graduate students watching the hands and marking the results. And one of the subjects he's been in many split brain studies. It turned out that his right brain had a higher opinion of himself than his left brain. And this was statistically significant. And the other gentleman is scored similarly in both hemispheres. But when we were setting up, he mentioned that he'd been bullied as a child. And I know that bullying is a severe trauma. And I asked him if he was upset by the bullying. And he said, no, of course not. It happened so long ago. You know, he was around 50 years old now. And so when we did the study, I put in about 10 different questions about the bullying, how upset he was about the bullying. And as he told me, his right hand signing for his left brain indicated that he was not upset by the bullies, but his left hand signing for his mute right brain was extremely upset by the bullies on all the questions that I had asked. And when we published it, we wrote that it was our opinion that the right brain was upset by the bullying, whereas the right brain wasn't. Now, this is a picture of Werner Wittling, who's a German scientist who somehow I came upon a paper that he had written. And he had a very elaborate machine, which I think must have cost $1 million. And it tracked eye movements and blocked the computer screen. And the purpose of it was to show a movie in free vision to one hemisphere or the other. And essentially, after I read the protocol about 5 times, I figured out that he was showing the movie to one lateral visual field or the other. And I didn't have the budget for that. So I figured I could do the same thing by going like this. And so I'm looking at my left lateral visual field or my right lateral visual field. And I should be able to do the same thing that the Wittling is doing. So I didn't respond when I went like this or like this. Years later, I did. I went to the office and tried it. My first patient that day was a Vietnam vet who had severe PTSD, and he was doing very well. And I asked him to do it, and he got all upset. He's looking out his right visual field, which is stimulating his left brain, and he says, that plant behind you looks like the jungle. And he had 4 tours of duty in Vietnam and a Purple Heart, and he's obviously having a flashback. So I said, well, look out the other side. And he smiles. He says, no, it's a nice looking plant. And I knew that I was in business. And that day, I had a bunch of people who had intense responses like that. About 55% of people respond intensely like this. So it's not an unusual, it's not like a rare event where someone responds intensely. And I had an experience that I described in my book where I was on vacation in Italy and had a very intense response. So here I am, I'm using my hands to block vision. And then later we advanced, science advances, and we had goggles that had tape on them. And this shows how it affects the retina. And so something to this field is going to stimulate the right brain. And so what I see is if I ask someone to get some junk mail like this and have them block their vision, that I'll look different on one side than the other. And the side that's negative is a trait for the individual. And so it could be either the left side or the right side that's more holding more of the trauma. And on one side, I might look very critical, and they'll have drug cravings or alcohol cravings or gambling cravings or anxiety or depression, but whatever their symptoms are. And on the other side, there's a big change. There's a big drop in their cravings. And I look more friendly and helpful, and they like themselves better. So that they're the same person, but there's a very important change that seems to relate to their traumas. So here's a picture. There's a really tough guy on the right side there. I wouldn't, mess with him. But the other guy looks a lot friendlier. And so the idea is that each hemisphere has a mind. And neuroscience over the last 4 decades, with trillions of dollars, has looked for measles in the brain. And fMRIs come up with measles, and we say, well, the left amygdala was active when we did this, and we don't really know what that means. But I'm saying that the important structure is the hemisphere with all its different components. And the hemisphere can support a somewhat different. This is an fMRI study that we did at McLean and published. And so the instructions were look to the left for 30 seconds and look to the right for 30 seconds. And the contralateral hemisphere became active depending on which side they were looking at. And so they're very simple instructions. And we didn't see anything in the individual fMRIs except in the visual area. There were 7 individuals. And when you looked at you crunched all the data, you got an image like this. So this is a guy who, I won't read through this, but after I was seeing that I was getting these interesting responses, I had treated him well for a cocaine addiction. And he came back, and what we found when I treated him was that his father was demeaning toward him. And so when he looked at one side, he could feel the pain of his father's rejections. And out the other side, his father didn't bother him. He said, I could handle him today. So I had him look out the negative side again. I said, would you use? He said, well, with these glasses on, yeah, I could see myself using. And when I put him on the other side, he said, no, I wouldn't use on this side. I said, what would somebody have to do to make you use on this side? He said, they'd have to do some extreme things. And so if you want to try this at home where you are now, you can do it. Results are kind of immediate. So if you block one eye and the middle of your other eye, and what a lot of people do is they look out the whole eye, and you have to look out half the eye to get the lateral visual field to be able to cross over. What you have to do is give it a minute, give it about 60 seconds, and I want you to think of something upsetting and see from 0 to 10 how much distress you feel on one side versus the other. And again, not the whole eye, but half the eye like that. Okay. And I use this in psychotherapy. It's very easy. I have a person look out one side or the other, and I can talk to the troubled side. And the idea of I call dual brain psychotherapy is to talk to the troubled side and try and educate it about its trauma and get the healthy side to be a co-therapist. And I find it's a very effective treatment. This is a study that we did at McLean. This is just an MRI study. And we found that people who had a positive left hemisphere had a larger nucleus accumbens in their left brain, and that's for the reward center. They had a smaller amygdala and a larger hippocampus in the left side. They also had, there's an interesting finding here where they had the green button here is the amygdala, and the left amygdala. This is where the people had a left positive hemisphere, and these are frontal lobe areas that suppress the amygdala. And they're absent. These are tracks. This is a DTI study. And so the suppression from the frontal lobe is missing, at least in this study. And so because we weren't sure it varied which side was positive, we did a study to predict who would respond to TMS. Our TMS is always given to the left side. And no one knows why it's always given to the left side. It's just that there's a sort of common wisdom that the left is always good and the right's bad. But what we found was that people who had more distress in their left brain did poorly. That's if it's high up here, they had a less. This is a decrease of 10%. So they didn't even reach 10%, most of them, and their average was about 7% decrease in their Hamilton scores after a 2-week course of TMS. those who had a positive left hemisphere, just with the visual test, scored better. All the people who did well, except for one left-handed woman, were predicted to do well by the visual test. And then we replicated that in another study. And then I became interested in, because I was looking at RTMS, and I didn't want to lug the heavy machine up 3 flights to my office. So I got interested in photobiomodulation. And the only thing I really knew, I was doing some near-infrared spectroscopy, which uses near-infrared light to measure blood flow and cerebral oxygenation. And so I wondered if near-infrared light might get into the brain and stimulate the hemisphere. So that's where I was coming from. I didn't have really much technical knowledge. I read a number of papers, but I was not at all an expert in photobiomodulation. So I called the Wellman Center at MGH, and it was a cold call. And I got passed around to a bunch of people, and I asked if it would be dangerous. And they said, well, if it doesn't hurt the skin, it won't hurt the brain because it decreases in intensity. But the square of the distance was really that interested. And I finally, there was a guy I got passed through named Mike. And Mike seemed quite interested. And we wound up doing a study. And the study is probably my most cited paper. What we did was I brought in, it was a pilot study. I had 10 subjects. Most of them had a history, but not active substance abuse. And they had depression. And our main outcome was the Hamilton Depression Score. And after a single treatment, by the way, let me go back to Mike. Mike turns out to be Michael Hamlin, who's probably the most famous photobiomodulation person. And so he developed the parameters for the light and, guided me with the safety. And so we have a light, it's at 810 nanometers and has 240 milliwatts of power. And a 4-minute treatment. We were using the ANSI standards for safety. And the results that we got 2 weeks later, our outcome was a Hamilton at baseline, and then a Hamilton 2 weeks later, and then 4 weeks later. It was about a 40% drop in the Hamilton at 2 weeks. And then it went back up to, there was like a 20% drop at 4 weeks. The one treatment in these 10 people had some profound effects. And then we treated both sides because I had to get through the IRB at MGH, and I felt that if I started talking about dual brain psychology, I was going to wind up in a swamp. And so we just treated both sides, which is what most people do in the field. But I wanted to, in my practice, I got an IRB involved, and I was using the LED that we had developed to treat the positive hemisphere. We used a continuous light to stimulate the positive hemisphere. The point here is that it was the same responses we got with the visual thing, except that it was about 2 or 3 times more powerful. One guy I mentioned, Brooke, came in. He came in for alcoholism, and asked him if he had any cravings, and he said he did. And I said, well, I have a beer in my refrigerator. We had an auction, and he was willing to give me $500. And I gave him a 4-minute light treatment over his positive hemisphere. And the way we determine which hemisphere is positive is using the visual test. And I have other means of pushing that if a person isn't showing much of a difference. Let's say that the person responded, and most of these people will have more cravings on one side than the other side. And anyway, I gave him a 4-minute light treatment, and he didn't want the beer in my refrigerator, and he didn't want to pay $400 or $500 for it. And I said, well, I'll give it to you, and he wouldn't take it. And this is not uncommon. There's a patient who I'm treating now, and he'll come in and he'll be depressed. He did well in the last session, but by the time he comes in a week later, he's depressed again. And so he might have a depression score on a Beck depression scale of 34. This is a paper that I'm just submitting for publication. And after a light treatment, in this one instance, it went down to 4 that I remember. But whenever I treat him, he has a dramatic improvement in his depression. Now, it doesn't last. He really should get treated twice a week. And I see him once a week, and he gets treated when he comes in for his therapy session. And I'm trying to show him that he has the potential to be healthy. He's been living all his life in a depression, and we trace that back to severe abuse by his father and how that abuse was rolling and created other abuses. And so it's been a fight for about 3 months. He's still in treatment, but he's hanging in there, and I think he's going to do well. I can't say he's doing, he's sort of with the program, but he's not quite there yet. The negative side is very strong, and it's been dominating for years, and it doesn't want to retire. It doesn't want to go on disability. These are the results of a craving study that I got a grant from NIDA, and we studied half at McLean and half at a company that I started called MindLight. And we both got the same results, both at McLean and at MindLight. And we studied 40 individuals. Half got sham and half got active treatment. And what we were looking for were cravings. These were opioid addicts who weren't using, except for out of 40, 10 were using. And there was a big difference in the outcomes favoring the active treatment over sham, had an effect size of 1.5, which an effect size of 0.8 is considered high. So it's really twice high. And it's a very good effect size. Prozac has an effect size of about 0.3, which is quite low, and it remains very popular today. So from this, we got a phase 2 grant from NIDA, and the FDA gave us a breakthrough designation to study mild and moderate opioid abuse. And what we found was that there isn't any mild or moderate opioid abuse anymore. That we've gotten rid of oxycodone. Nobody can prescribe it anymore for pain, so people with pain aren't getting treated. And so everybody's turned to fentanyl. So there's a vast epidemic, I think, throughout the world, but certainly in the United States and in Boston, the fentanyl addiction is a blizzard. And we're in the middle of our treatment study, and at our site, we've had about 60% of the people dramatically drop their fentanyl use. And I think that people have dropped out. That's why it's 60%. I think the number of the sham people dropped out. Of course, I don't know that. I'm blind to who's getting sham or active. But probably it won't be till next August when we complete the study that we'll be able to unblind the study. In the first study, where we saw the decrease in cravings, we also had a big decrease in use. And it turned out that the decrease in use was dramatic at McLean, but at MindLight, it was like a flat line. There really wasn't much a difference. And the FDA was interested in that. And so I went back after we had published our papers published in Frontiers, either in psychiatry or psychology, I don't remember which. And I looked at the people who were using, the 10 people, and 5 of them were treated at McLean and 5 were treated at MindLight. And at McLean, just by chance, by randomization, 4 out of 5 got active treatment. And the one who got sham dropped out. His using wasn't recorded. And whereas at MindLight, 4 out of 5 got sham. And the one who got the active treatment actually did very well. He was a heavy heroin addict who, by the end of the treatment, wasn't using. And his girlfriend was in the sham group, and she was trying to get him to use, and was using a lot. And so hopefully we'll have good results with fentanyl. And when we started to see that, oh my God, we're treating fentanyl, and we weren't prepared for it, and we would have designed the study differently. We're treating twice a week for 6 weeks, and then once a week for 19 weeks. And that was to save manpower, but they really need to be treated at least twice a week. And then we would have really gotten a much better result than we will get when we're done in the present study. So this is in the first study. This is just showing that there was a decrease in positive urines favoring the active treatment. In an earlier study that I had published, I just want to show that the Hamiltons were decreased from 15, which is just a borderline depression, down to 8. And this is the Hamilton Anxiety Scale went down to, so this is about 9 and this is about 8 here. And the cravings, this is with a single treatment, it went down 51% versus, can't read that, but it's a smaller amount in the placebo group. So one treatment, they got either active or placebo, came back the next week and got the opposite treatment. And then a third week, they got an evaluation. And we found that the effect came a week later, that we didn't see an immediate effect. But in a recent study that I'm publishing now, using the Beck Depression Scale before and after a unilateral light treatment, that we saw a very powerful effect over sham with our treatment. This is the Beck Depression score. This is some months ago. So there was in the active group, there was a 40% difference versus 16% in the sham. But this is incomplete data. It's a more complicated study than this. So dual brain psychotherapy, I sort of mentioned, is trying to really work with the traumatized, to really deal with the trauma in one brain hemisphere. And it's complicated because that hemisphere is kind of determined to repeat the trauma and do all the things that Freud talked about with repetition compulsion. But I find that in the majority of people, it is successful. And that I've had people with profound depression get recovered in 6 months, which I had never been able to do before. This is my first book, and Cantos Pert, who discovered the opioid receptor, said that I rivaled Freud. And then I later found out that she was talking about Sigmund's brother, Ludwig Freud, the baker. And so I was disappointed with that. Joe Bogan, who I was very friendly with before he died, said this is wonderfully readable and well informed. It's the best book ever on the social and psychiatric implications of the split brain research. So that's available on Amazon. And then October 15th, we hope to have this second book out, which has research over the last 25 years, which are included in the first study. And it's an easier read. The first book, I think, put people off because it seemed too technical. And so this is to be a kind of a friendlier book. And then these are sunglasses that we use in the treatment. And you can put them on and you can elicit one side or the other. Instead of using an envelope, the person can continue to see you, but they get that effect. And then we're developing stress reduction glasses so we don't have to go through the FDA. And so Patricia has an open query.
Yes. Do you, and Dr. Schiffer, do you keep the glasses on during your treatment, or do you just do that as identification?
Well, both. I can usually I just use them to talk with one side or the other, and then we take them off. But they have them at home, and I think I would say 95% of my practice has them at home and loves them. And so one guy's an investor, and he has to wear his glasses to calm himself down so he can invest. And
wow.
They're actually, in my experience, quite powerful. And here's the talk I'm giving on the 30th. And you don't have to be a clinician. If you're a clinician, you can get CEUs. But if you're not a clinician, you can still come, but you won't get CEUs. That's it. Any questions?
I just wanted to ask one more thing. Are these people who have the photobiomodulation equipment at home as well?
I generally didn't because it's not approved. So everything that I do is under IRB supervision.
Is Neuroimaging not yet approved? FDA approved?
No, it's not FDA approved.
We have no medical device license. There's right now in the United States no FDA approved.
We're applying for FDA approval with this fentanyl study, but it would be limited to fentanyl treatment if we get approved. But we're still doing the study. McLean's having trouble enrolling people. And so we're working hard, and hopefully we'll have great results a year from now. And we'll get FDA approval to treat fentanyl addiction. And then we'll have to do another multi-million-dollar study, get FDA approval for depression and other indications. It's a difficult system. I mean, it costs a fortune and takes forever. And so FDA approval is very difficult. All of the work that I'm talking about has been done under IRB supervision as a study. So, but I did give one patient who is a physician a light to take home, and she uses it at home and finds it very helpful. And I had three patients who were suffering a psychosis, and I gave each of them a light to take home. And initially, I got great results, and they were like transformed. And then it failed, and I think the negative side took over. And I think if they were in a hospital setting and getting treated every day, or a couple times a week, that they probably would have a good outcome. So I took back all the lights for the psychotic patients. I felt that it in the end was not helpful. I don't think it was harmful, but I didn't want to have devices that were not approved, floating out in the community. So I have given some at home, and just in the physician is out on disability. I'm trying very hard because she's a very important physician, and I'm trying to get her back to work. And I think we'll succeed with that. But I sort of broke the rules to try and help her.
I really wanted to thank you for your first book. I read that book, and I've been a long time neurofeedback provider, and I actually appreciated the technical detail that was in the book. But I made goggles for people to use while they were doing neurofeedback. Hope to be able to do a full study with it, but in clinical practice, it makes it kind of difficult to do that. But one of the things that I certainly observed was it really sped up the response to the neurofeedback. I thought it had great application. So
great.
I appreciate that.
I have an idea that if you took my light, which is a single light, and placed it over the area that you're trying to increase, say beta frequency, or you could pulse it at a slower frequency, you probably could augment neurofeedback with biomodulation.
Has anybody done neuromodulation with neurofeedback together at the same time?
I do them sequentially. I do them back to back, and like within PBM and then neurofeedback back to back, for what it's worth.
Yeah, I think Dr. Roselle here in Sarasota does that.
I think I've also started sequentially.
I've just got two quick questions, if that's all right. The first question is, you using your studies one side of the brain of PBM application. I just wanted to know what your thoughts would be on if you use PBM on the other side as well as the left hemisphere. So you use PBM for both hemispheres. Would that, or in your opinion, how would that impact results, if at all?
Well, I think my feeling is that you'd be activating a negative hemisphere, and so you'd be sabotaging yourself. But there's a study that I looked at the two sides versus I have a novel device, and whether I see a huge difference with the single light. With the novel device, there was a big difference between bilateral and unilateral. And the novel device tries to inhibit the negative hemisphere. And so that was off the chart better. But the results showed that there was a better performance with the single light than bilateral, but it wasn't statistically significant. And the study is sloppy in that it was under IRB supervision, but it was with patients in my practice. It was a single blind study, and patients came in, when they had an appointment, and sometimes they would say, I don't want to fill out the form today. And so it had a lot of defects with it. I'm submitting it because the Army is applying for a big grant and for depression, and they want to get more provisional data, and that's why we did the pilot study. So it's clearly marked as a pilot study with a number of defects in it, and it's not, like our FDA study. We have a study monitor who is like a hawk, and if we don't, somebody takes an aspirin, it's an adverse event, and we have to report that.
Thank you. I just have another question. It's more along the conceptualization of dual brain psychology. In your opinion, how would you say, when you look at both hemispheres, that's great. But what about the brainstem? How do you think that plays a part in the dual brain hemisphere?
I don't think it does.
You don't?
I don't know that. I only know what I see. And what I study, and it's very hard to study the brainstem. But I think that the real action is in all of the computations that go on in making brain information in the two hemispheres, and that there is different brain information in the left brain from the right brain. And so I think the brainstem is more related to ness and bodily control. And that's my opinion. Carl Anderson is very excited about the cerebellum and feels that that's very important. I don't have an opinion about that.
Thank you.
Thank you.
Okay, well, you're welcome. I enjoyed it immensely, and I hope that you come to the symposium, which will be, it's a longer meeting, and so we'll get into really the psychotherapy piece and the treatment. Okay, thank you.
Thank
Thank
you.
you.
Thank you, everyone.
Thank you.